The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Now let's discuss your Nsaids or your non-steroidal anti-inflammatory drugs, your acetaminophen or paracetamol, your Dmards, disease-modifying anti-rheumatic drugs, and your drugs used in the treatment of gout. Now, in discussing all of these medications, we do have to touch a bit on inflammation. I know you've discussed it extensively in pathology, but I just want to remind you that inflammation is your response to injurious stimuli, okay? So it could be noxious agents, it could be infections, it could be injuries. Now, mediators of inflammation. What are your mediators of inflammation? So we have cellular mediators. Just get my pen, okay, like your white blood cells. And you also have chemical mediators like your serotonin, your histamine, your bradykinin, and most importantly, perhaps in the discussion of this drug class are your prostanoids, your prostaglandin E2 and your prostacyclin or your PGI2, okay? Now, all of these mediators of inflammation, they function to eliminate the cause of injury, they clear away debris, and they prepare for tissue repair. So they're all very important. However, they also cause what we call peripheral sensitization. Okay, so what is peripheral sensitization? Essentially, your nociceptors, like your unmyelinated C fibers, in response to these mediators of inflammation, they send signals of pain to our central nervous system. And it is this peripheral sensitization that the Nsaids aim to reverse. Okay, so Nsaids function to reverse the peripheral sensitization caused by mediators of inflammation. So how do they do this? Nsaids, or your non-steroidal anti-inflammatory drugs, they work by inhibiting an enzyme called COX, or cyclooxygenase. And I'll talk a bit about COX later, but I just wanted to give a general overview of the classification of Nsaids. So you can have your salicylates, your aspirin, aka your acetyl salicylic acid. You also have your non-selective Nsaids, meaning they inhibit both COX-1 and COX-2, and I'll explain the difference of the two enzymes later. Or they can be COX-2 selective, meaning they only inhibit or they specifically inhibit COX-2. Now, it is because of this inhibition of COX or cyclooxygenase that they are able to prevent the production of prostaglandin. So bakit nga ba? COX is also actually called prostaglandin G or H synthase. So they are the same thing. And that gives you an idea as to what their function is. Cyclooxygenase is the first step in the production of your prostanoids. Okay, it is the first enzyme. And you have different types of cyclooxygenases. So diba kapag non-specific, they inhibit both 1 and 2. So what's the difference? COX-1 for number 1, because they keep the house clean. They are housekeeping enzymes. They maintain the integrity of your mucosal lining through the production of prostacyclin. The mucosal lining, its integrity and also its protection is dependent on prostacyclin, which is why we get NSAID-induced gastritis when we take too many Nsaids. They are also important in platelet function because it is through the cyclooxygenase pathway that we produce thromboxane A2, which is very important in platelet aggregation. Take it in contrast to COX-2. So the way I remember COX-2 is may dalawang sungay ang devil. So it's the evil one because it is responsible for the formation of prostanoids in inflammation and cancer. And it is upregulated by stress and cytokines. So obviously inflammation is important. It means we're able to mount an immune response, but it is also what causes pain and tissue damage. COX-3 is found predominantly in the central nervous system. It's not that well known yet as to what it actually does, but we do know that it is found in the central nervous system. Now, going back to the previous slide, because we know what COX does, let's discuss the toxicities in relation to COX's mechanism of action. So as I mentioned, the gastrointestinal tract lining is dependent on prostacyclin to maintain its integrity. Therefore, NSAIDs can cause GI bleeding via a bleeding ulcer. It can also cause nephrotoxicity, leading to renal insufficiency, renal failure, hyperkalemia, and proteinuria. So how does it cause renal toxicity? So for that, I'll ask you to look at the figure on the left of your slide. So the afferent arteriole, meaning the arteriole that provides blood to the glomerulus, Okay, it is dependent on certain vasodilators to keep patent. And one of those vasodilators is your prostaglandin. So imagine if you give an NSAID, you would inhibit prostaglandin production. Therefore, you would constrict the afferent arteriole, you would decrease renal blood flow, and you would decrease the glomerular filtration rate. Now, imagine giving an NSAID to somebody who already has poor kidney function, somebody who's CKD3 or CKD4. That could exacerbate their already low GFR and cause these things on the slide: renal insufficiency, failure, hyperkalemia, proteinuria. Okay. Another side effect that is quite common in NSAIDs is hematologic side effects. So it can cause bleeding, remember, because it inhibits the production of thromboxane. It can also cause thrombocytopenia, and in rare cases, it can cause aplastic anemia. In patients who have very poor cardiovascular health, it can cause a decompensation of existing heart failure. So NSAIDs, even though a lot of them are over the counter and we tend to give them left and right, do know that they're not their safety profile isn't 100% safe, as with any drug. But I think NSAIDs in particular, they're given a bit too liberally. We should be cautious as well of their side effects. Okay. So remember, I discussed COX-3, which is found predominantly in the central nervous system. So this is where it becomes relevant, because paracetamol or acetaminophen, phenacetin pala, guys, that is just one of the older drugs. So phenacetin converts into acetaminophen, which is the active metabolite. So anyway, the drug works by selectively inhibiting COX-3, which, if we remember, is found predominantly in the central nervous system. It does inhibit COX-1 and COX-2, but only weakly. So it still inhibits peripheral prostaglandin synthesis, but not as well as your other NSAIDs, which is why its analgesic property is only mild. And if I ask you, is paracetamol anti-inflammatory? Well, the general consensus is that it has no significant anti-inflammatory effects, meaning its peripheral inhibition of COX-1 and COX-2 is so weak, we don't really count it as an anti-inflammatory. And remember, I discussed peripheral sensitization earlier in regards to pain. So the analgesia it offers is only quite mild, but it is a very good antipyretic, something that lyses the fever. So why is it a very good antipyretic? Remember that the CNS contains COX-3. And how does the body set a fever? It sets a fever via the hypothalamic setting point. So the hypothalamus decides what temperature to set the body. Now, in the presence of your pyrogens, so things that generate a fire, pyro, a fever, things like your IL-6, your TNF-alpha, and your interferons, okay, the hypothalamic setting point is increased. It is also increased in the presence of PGE2, prostaglandin E2, because this can cross the blood-brain barrier, enter the central nervous system, and trigger an increase in your hypothalamic setting point. Therefore, if you inhibit the production of PGE2, it is unable to cross the blood-brain barrier as well. It is unable to set the hypothalamic setting point as high, and therefore it is very good for fevers. Okay? It is very well tolerated. It doesn't have quite the same side effects as NSAIDs, but one thing that we do have to note is its propensity towards hepatotoxicity, especially in high doses. And this is particularly prevalent in patients who have chronic alcohol use disorder. So alcoholics are even more prone to hepatotoxicity, and I'll explain why later. It is also the preferred antipyretic in children with a fever because it is not associated with Ray's syndrome, unlike aspirin, which we know is associated with Ray's syndrome. So let's discuss paracetamol toxicity. So it is the most common cause of acute liver failure in the West. I believe in less developed countries, this is hepatitis. But in more developed countries, it is paracetamol toxicity. So how does it cause paracetamol toxicity? So I'll ask you to look at the figure on the right. Essentially, your acetaminophen, the majority of it, okay, is metabolized via your phase 2 reaction. So you'll see about 38% undergoes sulfation, 54% undergoes glucuronidation. A small percentage, about 5%, undergoes your phase 1 metabolism via your CYP enzymes or your cytochrome enzymes. And this is one of the explanations as to why chronic alcoholics are at an increased risk of paracetamol hepatotoxicity. What does chronic alcoholism do to our CYP enzymes, our cytochrome enzymes? Chronic alcoholism is an inducer of your cytochrome enzymes, meaning it upregulates the activity of CYP. So if you're upregulating CYP enzymes, you're producing more and more of your NAPK, and therefore you're increasing the toxic intermediate because NAPK is the toxic intermediate that causes hepatocyte death. Now, in healthy patients, they are able to detoxify this toxic intermediate because their cells have a lot of stores of the antioxidant called glutathione, or your GSH. So with glutathione, it's able to detoxify your NAPT and it's able to secrete it into or excrete it into your urine. However, if you have low glutathione stores, which is usually the case in chronic alcoholics because they tend to also have poor nutrition, you are unable to excrete it in your urine, and therefore it results in hepatocyte death. Now, if we were to ask what type of hepatocyte death it causes, the pathology behind it is a dose-related centrilobular hepatic necrosis. Okay? So how do we treat paracetamol toxicity? We give NAC, or N-acetylcysteine, which substitutes for your glutathione in order to detoxify naphtine. Okay? Paracetamol toxicity is dose dependent. Okay, so the dose makes the poison in this case, and generally in adults, the dose that is considered toxic is 150 milligrams per kilogram. It depends on the reference. Some will say 150 to 250, but this is the range that we would expect to see hepatotoxicity. So for a 70-kilo man or woman, that's about 10 to 15 grams in one dose. So maximum of 30 tablets of 500 milligrams of paracetamol. If you go up to 20 to 25 grams in one dose, that is potentially fatal, meaning it can kill you. Now, what are the manifestations of hepatic toxicity because of paracetamol overdose? So it depends on the time period. Immediately after ingestion, so about 4 to 12 hours after, you will develop GI symptoms, so nausea, vomiting, abdominal pain, etc. The clinical signs of hepatic injury start to show 1 to 2 days after, so 24 to 48 hours. It depends on the reference you're reading, but 24 to 48 hours is a good range to study. This is when patients will start to complain of right subcostal pain. They will start to you will start to be able to palpate hepatomegaly, and this hepatomegaly tends to be tender or painful. But really, the peak of hepatic injury occurs at 3 to 5 days after ingestion. And this is when you start to notice a maximal elevation of your liver enzymes. It can go as high to over 10,000 units per liter. You will start to see jaundice, hepatic encephalopathy, coagulopathies because of the liver failure. And patients I've seen who have reached this level of hepatic failure, unfortunately, have required liver transplants. Because unlike patients with kidney failure, whom we can dialyze, we don't have a way to remove ammonia from our body the way that the liver does. And so the only solution really is a liver transplant. So that's how serious paracetamol toxicity can get. Moving on to our next drug, we have aspirin, or your acetylsalicylic acid. So aspirin is an irreversible inhibitor of COX-1 and COX-2. So it reduces platelet production of thromboxane A2, which is a potent stimulator of aggregation. That's why aspirin is an essential part of our dual antiplatelet therapy for patients with MI, strokes, etc. At low doses, it produces an antithrombotic range. At highest doses, it produces an anti-inflammatory effect, which is why we can give it in inflammatory diseases like rheumatic fever and Kawasaki disease, which is the only time we would give aspirin in a child, because otherwise, aspirin is associated with Ray's syndrome, which I'll discuss a little bit more later. I also wanted to discuss the side effects quite specific to aspirin. So remember, most NSAIDs will have the same nephrotoxicity, GI toxicity, HEMA side effects. Aspirin also has a few special things that you guys need to note. One of it is hyperventilation. So bakit hyperventilation? Essentially, salicylates, they increase oxygen consumption, meaning your body is using more oxygen. And by using more oxygen, it increases CO2 production. The reason it does this is because at high doses, aspirin acts as an oxidative phosphorylation uncoupler. Okay, so it uncouples your oxidative phosphorylation. Therefore, with your increased CO2, this then triggers the medulla, okay, to start hyperventilating so that you can blow off more of that carbon dioxide. You can excrete it from your system. So we know what happens with hyperventilation, diba? Your CO2 goes down, and what happens to your acid base? You get acidotic or you get alkalotic? You get alkalotic. Okay, particularly respiratory alkalosis. In addition to this, salicylates also cause direct stimulation of the medulla to trigger respiration. So both of these things together cause increased respiration. So you already have respiratory alkalosis. So doc, bakit HAGMA yung nakasulat sa slide or in your handouts if it's supposed to be respiratory alkalosis? So in response to the respiratory alkalosis, what do your kidneys do? They produce a compensatory metabolic acidosis, which they do by excreting more bicarb in the urine. So you have initially you had increased CO2, you hyperventilate, you decrease your CO2, and now your HCO3 is also going down in order to compensate for the respiratory alkalosis, okay? However, in this case, what happens is eventually you're unable to blow off all of that carbon dioxide and your CO2 starts to build up. So you start to get a bit more acidotic, but your kidneys are not able to respond quick enough. And therefore, you've already excreted your bicarb. Your carbon dioxide is starting to climb up. You now become acidotic, okay? And it's metabolic acidosis because your bicarb is low. And because your aspirin is a salicylic acid, meaning it's an extra anion, the anion gap increases. So it's high anion gap metabolic acidosis. It's the S in your mud piles. So that's the pathophysiology behind it. Tinnitus is also quite a key feature of aspirin toxicity. So if a patient presents with hyperventilation and tinnitus with an overdose from an unknown drug, it's most likely to be aspirin because those are buzzwords. Another thing unusual about aspirin toxicity is that it can cause hyperthermia, which is unusual or ironic because we use aspirin sometimes to lyse a fever. But in uncoupling your oxidative phosphorylation, remember that uncouplers lead to excessive heat production. So patients with aspirin toxicity can also present with hyperthermia. Okay. I also wanted to discuss the dosage ranges of aspirin because depending on what dose range you give, it changes the mechanism or it changes the therapeutic use of your aspirin. So if you give it in your low doses, so under 300 milligrams per day, it is very effective in reducing platelet aggregation, which is why whenever a patient needs to be on antiplatelet therapy for secondary prevention of stroke or heart attack, the dose that we give is 75 or 80 milligrams, the baby aspirin. Because that's enough. That's the dose that we need to achieve the antithrombotic effect. However, if we want to give an anti-inflammatory dose, the same way we would want to give it in Kawasaki's disease, our dose would have to be much, much, much higher. It would have to be at 2.4 to 4 grams per day. And the kinetics or the pharmacokinetics also changes depending on the dose that you give. So if you give a low-range dose or a low dose, it follows the first-order elimination kinetics. So quick review, ano nga ba yung first-order elimination kinetics, diba? It's that the rate of elimination is proportional to the concentration of the drug. So if there's a graph, okay, parang ganyan yung elimination niya. Whereas in zero-order elimination kinetics, what do we remember? We remember that in zero-order elimination kinetics, the rate of elimination is constant regardless of the concentration of the drug. So it's going down at a regular rate, okay? So at high doses, it follows a zero-order elimination kinetic, and at low doses, it follows your first-order kinetics, okay? Next, I just wanted to go into a pedia-patho-correlate related to Kawasaki's disease and Ray's syndrome. So again, aspirin is avoided in children because it has been shown to be associated with Ray's syndrome. So what is Ray's syndrome? It's defined as an acute encephalopathy with hepatic dysfunction stemming from mitochondrial damage. So some of the triggers are usually things like viral infection. So it causes beginning damage. And then they say that if you give aspirin, it makes this worse and it proceeds into Ray's syndrome. But the cause and effect of aspirin and Ray's syndrome hasn't been fully explained or teased out yet. But it is high yield to know that aspirin has been correlated quite strongly with the development of Ray's syndrome. We avoid it in children except in Kawasaki's disease. So we remember in Kawasaki's disease, one of the complications after the lysis of the fever or during the acute phase even is coronary complications. So why is that? In the acute phase of Kawasaki's disease, there is coronary vasculitis, which is an inflammatory process. Diba? The immune system causes thickening of your vascular walls and thereby causing coronary vasculitis. So the dose of aspirin we would give in the acute phase is a high dose because we remember that high dose is anti-inflammatory versus the dose we would give in the subacute phase, meaning after most of the fever has resolved, etc. We give a low-dose aspirin because the complications associated with this phase are thrombosis and myocardial infarction, which is a thrombotic process. So we no longer need the anti-inflammatory dose, we need the anti-thrombotic dose. Okay? Next, we have your non-selective NSAIDs. Again, they are reversible and they inhibit both COX-1 and COX-2. I just want to point out maybe a few high-yield ones on this slide. I mean, I think this is a relatively well-known topic amongst all med students. So what I would like to note is that misoprostol, okay, so remember I said NSAIDs can cause NSAID-induced gastritis. The best treatment for NSAID-induced gastritis is actually misoprostol, which is a prostaglandin agonist. Diba? We know that it's not legal here in the Philippines because it's usually used as an abortifacient. But in NSAID-induced gastritis, where you reduce the prostaglandin, the best way to fix it is to increase the prostaglandin via giving misoprostol. Another thing to note is that it can cause premature closure of the ductus arteriosus, which is why we don't give it in neonates unless we want to close their PDA, and why we avoid it in women in their later trimesters of pregnancy. Another thing I want you guys to note on this slide is ketorolac and dexketoprofen. So why are they special? It's because they can be given IV and they are used in post-surgical analgesic control. So they are very good post-op analgesics so that if a patient is unwilling to take opioids or does not want to be on opioids post-operatively, we can give ketorolac. However, it is such a good anti-inflammatory, sorry, not an anti-inflammatory, but an analgesic, that its use is generally restricted to 72 hours only because it has a high risk of GI and renal damage. So ketorolac, similar to paracetamol, has significant analgesic effect, but has very little anti-inflammatory effect. So think of ketorolac, really best way to use it is in pain control, especially post-operatively. Next, we have your indomethacin. So it also has your usual analgesic and anti-inflammatory effects. You may also be quite familiar with its use for the closure of your patent ductus arteriosus. So remember, it is given IV in neonates with a PDA. And up to 70% of neonates will actually respond very well to an indomethacin infusion. Pero when we give this, we always keep an eye on the urine output of these babies because remember, with NSAIDs, we have nephrotoxicity. Okay, so if we have a decreased urine output, this is signaling to us that the nephrotoxicity is already affecting the neonate. It is quite potent and non-selective, and it is thought to be up to 20 times more potent than aspirin. So it has a greater anti-inflammatory effect compared to other NSAIDs. So why don't we use indomethacin more often if it's such a good anti-inflammatory, if it's such a good analgesic? So the reason is up to 1 in 3 people, okay, so 33% will have an adverse reaction to it. So the most common pain, as usual, is your gastrointestinal, as with all NSAIDs. But even something like pancreatitis has been reported in patients who are taking indomethacin. It can also cause hematologic reactions like aplastic anemia, which is why it's not as commonly used unless there's a very specific indication for indomethacin. Next, we have your COX-2 selective NSAIDs, which, as if you remember, COX-2 is the principal source of prostanoid formation and inflammation and cancer. So they are more selective towards COX-2 and inhibit COX-1 only to a much smaller degree. Therefore, they have a much reduced risk of gastrointestinal toxicity because they're not affecting the housekeeping functions as much. And we can remember them quite clearly because their names have COX in them: celecoxib, eterocoxib, rofecoxib, valdecoxib, parecoxib. Okay. One thing that you should note about this drug class is there were 2 drugs, rofecoxib and valdecoxib, which were withdrawn from the market due to a paradoxical increased incidence of thrombosis. So they did find that there was an increased risk of things like myocardial infarction and stroke. So the way I remember it is Voldemort, he's an evil villain, and that's why he was withdrawn from the market because there was increased incidence of thrombosis. So the degree of COX-2 inhibition is almost 10 to 20 times stronger than their COX-1 inhibition, and therefore that is why up to 50% less of gastrointestinal side effects are seen. So let's answer a few questions on this chapter. So which drug was removed from the market due to an increased risk of MI? Heterocoxib, aspirin, celecoxib, or rofecoxib? So remember, it's rofecoxib. So I remember Rufus the Naked Mole Rat from Kim Possible. So rufucoxib and valdecoxib or Voldemort. So medyo pilit, but these are my visual mnemonics. So hopefully it might give you 1 or 2 points during the exam. What is the mechanism of misoprostol's gastroprotection in NSAID-induced gastritis? Is it smooth muscle contraction? Is it as an analog of prostaglandin E1? Is it via antagonism of histamine-induced acid release, or is it by inhibition of vagal nerve stimulation? So we know, as I mentioned earlier, NSAID-induced gastritis is via decreased production of your prostaglandins, and therefore it is because misoprostol is an analog of a prostaglandin, and therefore it helps with NSAID-induced gastritis. So we've covered your anti-inflammatory drugs, specifically the NSAIDs. Remember that your acetaminophen or paracetamol has very little to none anti-inflammatory significance, which is why it's under its own umbrella under Katsung. Next, let's jump into your disease-modifying anti-rheumatic drugs, okay, or your DMARDs. Now, I emphasize DM in DMARDs because unlike their cousins, the NSAIDs, DMARDs actually arrest or slow joint damage and disease progression in rheumatologic diseases. Remember that RA or rheumatoid arthritis is a multi-system disease. Yes, it typically presents with pain in the joints, but patients with RA also have to deal with increased cardiovascular risk, permanent disability, and disfigurement of their joints. So you can see in this photo, this is a patient who has severely disfigured joints because of rheumatoid arthritis. RA requires early aggressive therapy in order to prevent or to slow this from happening, and we want to maximize response to DMARDs whilst also minimizing long-term steroid therapy, because although steroids are very good for rheumatic diseases, we also know they come with many side effects. Now, there are 2 types of DMARDs I want you to think about, your CS DMARDs or conventional synthetic, or B DMARDs or your biologics, okay? Now, a lot of these drugs, practically all of these drugs are covered in other chapters, specifically your chemotherapeutic chapters, but I will discuss them again here. Okay, so first DMARD that we have to discuss is a cancer chemotherapeutic drug or your methotrexate. So a lot of your DMARD drugs are also used in cancer chemotherapy, and they will be discussed, their MOAs will be discussed in better detail during the cancer chemotherapy part of the lecture, but I will also touch on them here. So methotrexate, we know, is an antifolate medication. So if you look at this figure, we can see that it has quite a similar structure to folic acid. And its mechanism of action in relation to its purpose as a DMARD is via inhibition of ICAR transformylase and thymidylate synthetase. And because of this, it causes a buildup of AMP. Okay, so of intracellular accumulation of AMP, which is then converted into adenosine, which is then released into the system, and this is a potent inflammation inhibitor. We also know that it inhibits DHF reductase or dihydrofolate reductase, but in its relation to its DMARD's properties, according to Katsung, it's more because of its ICAR transformylase inhibition and thymidylate synthetase inhibition. Okay, so I do want to point out a few important side effects of methotrexate. So one of those is mucosal ulcers and hepatotoxicity. Another thing that is to note with methotrexate is it can cause interstitial pneumonitis. So I did have a patient who presented with shortness of breath. We were working up for cardiac causes, infection, pulmonary embolism, couldn't find anything. And then saw in the history he was on long-term methotrexate, had never been worked up or had never been followed up by his rheumatologist. And when we did a high-dose CT scan of his chest, we did find, unfortunately, pulmonary fibrosis, most likely secondary to his methotrexate. So he was taking this for his psoriatic arthritis at that point. So to note about methotrexate is it is the DMARD of first choice to treat rheumatoid arthritis. Okay, so again, we try to as much as possible, we try to manage rheumatoid arthritis without resorting to DMARDs. But if we have to, the first choice DMARD is your methotrexate. Another side effect that you guys have to note is bone marrow suppression. Bone marrow suppression. Okay, and when bone marrow suppression happens, so for example, you do a monitoring full blood count or a CBC, and you start to notice some cytopenias, it is in this situation when we do have to give the rescue agent, which is leucovorin or folinic acid. Because if methotrexate is an antifolate drug, then we have to give folinic acid in order to counteract some of its side effects. Okay. Some other DMARDs, which are also cancer chemotherapeutic drugs, and again, this will be discussed a bit better in the cancer section, is cyclophosphamide, which is a phosphoramide mustard. Essentially, it cross-links your DNA to prevent cell replication, and therefore your T cells and B cells, damay din dito, and it suppresses their function. So it can also be used in other rheumatologic diseases like SLE, vasculitis, etc. A key side effect or a key adverse effect associated with cyclophosphamide is your hemorrhagic cystitis. So if you remember your chemo man, the side effects of the chemotherapy, so I won't draw everything, but just so that you remember, there's a C and there's a Y, which looks like the bladder, to remind you that cyclophosphamide can cause hemorrhagic cystitis because cyclophosphamide, when metabolized, makes a toxic metabolite called acrolein. This is what causes your hemorrhagic cystitis, and the rescue agent for this is mesna. Okay. Next, we have your azathioprine, which again is another conventional synthetic CSD MARD and also a cancer chemotherapeutic drug. So it forms the active metabolite 6-thioguanine, which suppresses inosinic acid synthesis, also suppresses B cell and T cell function, immunoglobulin production, and IL-2 secretion, all of which are quite vital in the pathogenesis of your rheumatoid arthritis. So it can be used in rheumatoid arthritis, Behçet's, SLE, etc. Some side effects to note is bone marrow suppression, again, as is the case with most of these drugs, and an increased incidence of lymphoma. So that is something that is sometimes the paradoxical thing with some of your cancer chemotherapeutic drugs. It will treat the cancer, but it will also increase your risk of lymphomas or leukemias. And in this case, azathioprine is one of those drugs. Now, to note, azathioprine is eventually metabolized into the inactive form, one of its inactive forms via the enzyme xanthine oxidase, or your XO. We know that allopurinol is an inhibitor of xanthine oxidase. And so if you give allopurinol with azathioprine, you increase the doses of azathioprine and you increase the risk of toxicity. So don't give them together. Okay. Next, we have your anti-malarials. So this was discussed, I think, by Dr. Imran in the antibiotic section. And in addition to their anti-malarial effects, chloroquine and hydroxychloroquine, they're also useful in the suppression of T cells' responses to mitogens. So they cause decreased chemotaxis of your white blood cells, meaning the white blood cells don't go to the area where they are called, and are therefore also useful in patients with SLE and RA and not just patients with malaria. If you'll remember, during the early days of COVID, when hydroxychloroquine was being touted as one of the wonder drugs for COVID, a lot of your SLE and RA patients were affected by the reduced availability of this drug because it is a useful drug in rheumatologic diseases. Now, a very important side effect, so two that you need to remember, are synchronism, which is a triad of your headache, tinnitus, and vertigo. And of course, your irreversible retinal damage. Okay, so really important with hydroxychloroquine and chloroquine, they can cause irreversible vision loss. Okay, so because of their ability to do this, everyone who is on hydroxychloroquine has to be annually monitored with ophthalmologic exams. And if they find any evidence of retinal damage, we have to change the medication to a different DMARD. Okay, so those are your conventional synthetic DMARDs. I would like to touch on your immunomodulators as well. So this is a mix of both biologics and conventional synthetic DMARDs, but these drugs are also used in other treatments. So not just rheumatoid arthritis, but also in immune suppression for patients with transplants, for example. Because we know when somebody receives a solid organ transplant, we have to suppress the immune system so that our immune system doesn't attack the transplanted organ. So your immune modulators, they are biological response modifiers, meaning they modify how our body responds biologically. And they target inflammatory proteins, T cells, and B cells. And most of these agents will have quite a rapid onset of action. So let's discuss them. Again, this will be a mix of your biologics and your conventional synthetic DMARDs. So the first one up, and perhaps the most important, is your TNF alpha inhibitors. So these are your biologics. So you'll notice they end in MAB, 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 MAB. So these are monoclonal antibodies, MAB, monoclonal antibodies. They bind to and neutralize your TNF alpha, which we know is a pro-inflammatory cytokine. So if you look at adalimumab and infliximab on the slide, they look a lot like your antibodies. Now, sino yung naiba? Sino yung naiba sa name and sino yung naiba sa structure? So it's etanercept. If you'll notice, it doesn't end in a MAB, meaning it's not a monoclonal antibody. It ends in a sept. And that makes sense kasi it is a decoy receptor. Etanercept is a decoy receptor, okay? So it is a fake receptor that forms a complex with TNF alpha. And when it does form a complex with TNF alpha, it promotes the phagocytosis. So both types of drugs, the MABs and the etanercept, will eventually result in decreased TNF alpha and therefore decreased inflammation. So I have seen patients on TNF alpha inhibitors, particularly your infliximab and your adalimumab, and I saw them in patients with Crohn's disease, which is an inflammatory bowel disease. Again, inflammation, TNF alpha. Now, very important thing to note in a side effect is it can cause reactivation of latent tuberculosis. Okay, so remember TNF alpha is quite vital in the pathogenesis of your of containing your tuberculosis bacteria, your Mycobacterium tuberculosis, and therefore when you inhibit TNF alpha, you can cause reactivation of latent TB, which is why before we start anyone on TNF alpha inhibitors, we have to do a tuberculosis screening before starting the infusions. Another infection it can cause reactivation of is your hepatitis B. Okay. One thing also to note is infliximab has synergistic effects with methotrexate. So when given together, they are very good in allowing for disease remission in patients with RA. Another immune modulator that I want to discuss are your calcineurin inhibitors, specifically your cyclosporin. So just take a second to look at the image on the left with me. So don't get overwhelmed. Let's go through it. So merong antigen-presenting cells. So remember, these are members of your immune system, and they present a portion of an antigen towards a T cell. And this will allow the T cell to mount a cellular immune response. So the antigen-presenting cell, via its major histocompatibility complex, or MHC2, presents a fragment of an antigen they encounter. They present it to the T cell, who is able to recognize it via their T cell receptor, okay? This then causes or triggers an increase in cytoplasmic calcium, which eventually causes calcineurin, which is this protein over here, to dephosphorylate your N-fat. So it removes the phosphate group. And what happens when you dephosphorylate N-fat? Ano nga ba si N-fat? It's just nuclear factor of activated T cell. You don't need to memorize that. But essentially, all you need to know is whenever calcineurin is activated and it removes the phosphate group, what it does is it causes an increase. It goes into the nucleus and it causes an increase of transcription and translation of more IL-2, IL-3, IL-4, TNF alpha, interferon gamma, all your fun pro-inflammatory cytokines. So what cyclosporin does, which is this drug over here, it forms a complex with cyclophilin, okay? And together, they inhibit calcineurin from dephosphorylating your N-fat, okay? So it just stops whatever calcineurin is doing so that it doesn't produce all these pro-inflammatory cytokines. So it is quite a potent immunomodulator, and therefore, it is used very commonly in tissue transplantation. So again, because when you are a recipient of a transplanted organ, we have to make sure that your immune system is adequately suppressed so that it doesn't attack the transplanted organ. So patients with kidney transplants, etc., can be placed on cyclosporin. But ironically, one of its most limiting and most important side effects is its profound nephrotoxicity. So it is very nephrotoxic. Another side effect that you should note that it can cause is it can cause gingival hyperplasia. So I don't know why it's always a board favorite to ask about drugs that cause gingival hyperplasia, but what are the other drugs that can cause gingival hyperplasia? We know that phenytoin, can cause gingival hyperplasia, as well as your CCBs, okay? Another thing to note about the side effects, something I'll write down here, is that this drug is diabetogenic, okay? So it can increase the amount of, it can increase a patient's blood sugar, and a patient who is receiving a solid organ transplant is already on glucocorticoids. We know that glucocorticoids increase the amount of glucose in the system, kaya nga glucocorticoids. Plus, eto pa, you have a drug that's diabetogenic. So patients who are on both steroids and cyclosporine are at an increased risk of developing diabetes, okay? We have some other immune modulators here. We have your mycophenolate mofetil. What you need to know about its mechanism of action is it inhibits inosine monophosphate dehydrogenase, or IMP dehydrogenase, which is an important enzyme in the guanine nucleotide synthesis pathway. And B cells and T cells are highly dependent on the de novo guanine synthesis. Therefore, if you stop it, you inhibit their proliferation as well. So it's typically used in combination with steroids and a calcineurin inhibitor like your cyclophosphamide for prophylaxis of transplant rejection ulit. The principal toxicities are usually GI and hematologic, so gastrointestinal disturbances, reversible myelosuppression. But what's high yield about mycophenolate is to note that it has an especially increased risk of sepsis from invasive CMV infection. Okay, yun yung high yield kay mycophenolate. It's associated with sepsis from invasive CMV infection. And another thing, whereas the cyclophosphamide was very nephrotoxic, your mycophenolate mofetil is the least toxic or least nephrotoxic, especially for SLE patients or lupus patients who already have lupus nephritis. Next, we have sulfasalazine. I do discuss this drug a bit in your gastrointestinal drugs, particularly in the treatment of your inflammatory bowel diseases, but I'll touch on it here. Sulfasalazine, its active metabolite, which is sulfapyridine, inhibits the release of inflammatory cytokines, which is why it's used again in inflammatory diseases. So just an important side effect to note, remember, patients with G6PD deficiency can present with hemolytic anemia because this is a sulfa drug. Next, we have your abatacept. So before you wonder why are we discussing such sort of specialized rheumatologic drugs, I really don't want you to get overwhelmed by them, but they did come out. Some of these immune modulator drugs did come out, but not under pharma, under IM, under the rheumatologic part of IM. So I think it's worth discussing it pa rin. So abatacept, what this drug does is it inhibits the activation of T cells, bear with me, by binding to CD80 and CD86 on the APC, and it is a CTLA4 IGFC fusion protein. Okay, so that's a lot to take in. So let's look at the image on the left. Again, same thing. You have an antigen-presenting cell with a major histocompatibility complex and your T cell receptor. Essentially, what it's saying is the T cell receptor, in order to be, or the T cell, in order to be fully activated, it requires co-stimulatory interaction. So it requires other receptors to be activated as well. And one of those receptors is CD28 on the T cell, which binds to CD80 and CD86 on the antigen-presenting cell. Okay? So what does abatacept do? So, diba, it ends in sept. So, para siyang si etanercept. It's like a decoy receptor. So, if you'll see here, instead of CD28 binding to your CD80, CD86 on the antigen-presenting cell, si abatacept ang nagbind. It is a decoy receptor so that you prevent the co-stimulation of your T cells. Okay? Another thing to note about it is it also increases the risk of infection, and concomitant use with a TNF-alpha blocker is not recommended due to increased incidence of serious infection. And also, same as with TNF-alpha blockers, you should do tuberculosis screening before starting a patient on abatacept. Okay, next we have your leflunomide. So when it is metabolized into its active form, it inhibits dihydroorotate dehydrogenase, which again we know is involved in the synthesis of your ribonucleotides. And this therefore arrests your cells in the G1 phase of cell growth. So your T cells cannot proliferate and your B cells cannot produce antibodies. So again, useful in rheumatoid arthritis and psoriatic arthritis. One thing special about this drug is its metabolite. It is converted into its active metabolite in your intestines. And the name of its active metabolite is A771726. I don't think you need to memorize this. I've not seen this come out in the past few years of board exams. Leflunomide is also considered as effective as methotrexate in the treatment of your rheumatoid arthritis. A few more immune modulators. This one is a high-yield one, CD20 inhibitor, rituximab. So rituximab. Rituximab. Pilit, pero try to remember rituximab. It binds to the CD20 antigen on the surface of your B lymphocytes, okay? And this causes reduced inflammation by decreasing the presentation of antigens and also inhibiting the secretion of your cytokines. So it is used in moderate to severe RA. Another reactivation side effect is that it can cause hepatitis B reactivation. Therefore, before we start any patient on rituximab, we have to do a viral hepatitis panel before starting treatment. Next, we have your tocilizumab, tocilizumab 6, because it binds to IL-6. IL-6, we know, is a cytokine important in T cell activation. So again, it is also used in moderate to severe rheumatoid arthritis. Both rituximab and tocilizumab are only used if they do not have an adequate response to your TNF-alpha blockers, your infliximabs, your etanercepts. So similarly to rituximab, it also increases your risk of opportunistic infections. And again, TB screening should be done before beginning tocilizumab. So rituximab, hepatitis, tocilizumab, TB screening. And these are a few other immunomodulators, some other monoclonal antibodies, your secukinumab, which is against IL-17, your basilixumab, which is against IL-2. The way I remember basilixumab is I imagine two basil leaves na magkatabi. Ayan. Hindi siya mukhang basil leaves, but two basil leaves na magkatabi, IL-2, basilixumab. And ustekinumab, the way I remember it is paskuhan sa UST is on December 23, uste 12-23. So it's an anti-IL-12 and anti-IL-23. I have seen this used in clinical practice and it was used in Crohn's disease. Okay, so I understand that's a lot to take in, especially sa immunomodulators, but I think the most high-yield ones I tried to point out, the rituximabs, the tocilizumabs, your etanercepts, and your infliximabs. So don't get too overwhelmed with this section. Take it slow. Siguro make a few flashcards when it comes to memorizing which mAb inhibits which interleukin or which cytokine, but don't be too overwhelmed with this section, okay? Let's do a quick section synthesis so that we make sure that we remember all the key details. Nsaids inhibit formation of disinflammatory mediators. So remember, they inhibit your prostaglandins or your prostanoids. Which COX enzyme is important for housekeeping functions like renal perfusion and gastroprotection. So housekeeping, number one, we got to keep the house clean. Type of NSAIDs that have lower risk of GI side effects and their suffixes. So we know that's the COX-2 selectives and they end in coxib, heterocoxib, celecoxib. Only NSAID that irreversibly inhibits COX, remember it's your aspirin. NSAID of choice for PDA closure, the one that is 20 times more potent than aspirin, it's your indomethacin. Feared adverse effect when giving children aspirin is your Ray's syndrome, which again is an encephalopathy associated with hepatic failure from mitochondrial damage. Drug class that slows joint damage in RA slows, therefore it's your Dmards, your disease-modifying anti-rheumatic drugs. RA drug that can cause irreversible retinal damage is your hydroxychloroquine. TNF-A-alpha inhibitor that is not a monoclonal antibody. Sino yung naiba yung suffix? Kasi hindi siya antibody, kundi decoy receptor. It's your sept, etanercept. RA drug that inhibits calcineurin, you have your cyclosporin. What does leflunomide inhibit? Remember, it's your dihydroorotate dehydrogenase. RA drug that forms DNA adducts, as mentioned earlier, it's your cyclophosphamide. Biologic that inhibits IL-6, tocilizumab. RA drug that inhibits CD80 and CD86. This one is also another decoy receptor, ends with a sept, abatacept. RA drug that inhibits CD20, rituximab. Okay. So let's go through a few sample questions to make sure that we really understood. Rita was started on rituximab in addition to her methotrexate in the management of her severe RA. She was surprised to see how well it worked with her joints and asked you how the drug operates. What is the best answer? A, is it an NSAID? B, does it block the production of TNF alpha? C, does it inhibit beta cells during the B cells during inflammation? Or D, does it block interleukin 12? So we know that the answer is letter C. Okay. If it were B, it would be things. If it were B, it would be your other conventional synthetic DMARDs who block the production of TNF alpha. Your IL-12, if you remember, 12/23, December 23, is your ustekinumab, paskuhan sa ustek. Okay. Which of the following drugs will not slow the progression of joint damage in RAs? Is it aspirin, etanercept, methotrexate, or abatacept? So we know that the answer is aspirin because it is an NSAID. It is not a DMARD. Etanercept is your TNF alpha inhibitor by acting as a decoy receptor. Methotrexate, folate antagonist, first line, and your abatacept is your CD80, CD86 inhibitor. A 30-year-old female with rheumatoid arthritis and gout is diagnosed to have lung fibrosis. Which of her prescribed medications most likely caused the lung fibrosis? So again, a feared side effect of this drug, methotrexate, is your pulmonary fibrosis or your interstitial pneumonitis. Okay. Okay, next we move on to the pharmacotherapy of gout. So kung kanina yung DMARDs, baka maybe 1 or 2 or 3 questions lalabas. Itong pharmacotherapy of gout definitely lalabas sa boards. It's always asked, and it is a very important topic for future physicians like yourselves. So to understand the pharmacotherapy of gout, we have to remember what gout is. So remember, gout is a hyperuricemic metabolic condition, and it causes an inflammatory arthritis because of the chronic hyperuricemia, which causes supersaturation and crystal formation within joints and connective tissue. So essentially, if you have too much uric acid in your system, they have to find a way to go somewhere, and they tend to go to your joints. So they can go to the first MTP joint, causing the classic podagra seen in gout. They can go and cause tophi, which are like little masses on your elbows, etc., which is essentially a collection of your uric acid as well. Now, one thing to note about gout, whenever we discuss the treatment strategies of gout, when it comes to the uric level balance in the body. So imagine a seesaw, okay? So in one end of the seesaw, we have production, I'll put letter P, and in one end of the seesaw, we have excretion. So we have to balance the amount of uric acid that we produce, and we have to balance the amount of uric acid that we excrete, okay? So in gout, you either have too much uric acid production. Maybe it's because you ate a purine-rich meal, you had a binge drinking episode, ang daming pulutan, ang daming lamang loob, etc. You have a purine-rich diet, you degrade all of that into uric acid, and therefore your production is much greater than your excretion, and the scales tip. And whenever the scales tip, they go towards inflammation, thereby causing the classic symptoms of your gout. With excretion naman, it's also possible that you're under-excreting for whatever reason. It could be because you're taking a medication that is known to decrease the excretion of uric acid in your urine, or it could just be something else. But essentially, whenever you increase your production or decrease your excretion, or both, they both will tip the scales towards the favor of inflammation and your gout. Therefore, all the treatment strategies of gout will either target the inflammation, such as your Nsaids, except aspirin, and I'll explain why, or colchicine, because they reduce the inflammation during acute attacks, helping with the extremely, extremely painful attacks of gout. Or you could increase the excretion by giving uricosurics, by accelerating renal excretion of uric acid. So uric acid, osuric, so you excrete it in your urine. Or you reduce production by reducing conversion of purines to uric acid, which is done via your xanthine oxidase inhibitors. So that's really all you need to know about the gout medications. You will either increase excretion, decrease production, or fix the inflammation. One thing to note, uric acid levels can be normal during an acute attack, and you can think of it, if all the uric acid crystals are in your joints, they won't be detected in your blood, okay? An aspirin as an NSAID is not used in the treatment of gout because it can cause renal retention of uric acid at low doses. And I'll show you an image that demonstrates that, okay? So eto na naman tayo with aspirin. We remember its mechanism of action or its use differs depending on the dose. If it's low dose, it's antithrombotic. If it's very high dose, it's anti-inflammatory. Same with its relationship with uric acid. If it's low dose, it promotes uric acid retention, so bad for gout. If it's at a high dose, it blocks uric acid reuptake, meaning you cannot absorb uric acid in your kidneys, therefore you excrete it. So it's uricosuric, so it's good for patients with gout. But generally, most of the patients you meet who are on aspirin will be on a low dose of aspirin naman kasi we typically give it for its antithrombotic effect. So look at this. Orient yourselves. This is the blood, this is the urine, and this is your renal proximal tubular cell. At the basolateral side of your renal proximal tubular cell, you have a channel that absorbs or that allows urate to be excreted into the urine. At low doses of aspirin, this channel is blocked. Whereas at high doses of aspirin, the reuptake channel, where urate is reuptaken from the urine into the blood, at high doses, this is blocked and therefore it is uricosuric. So again, low dose, uric acid retention, high dose, uricosuric. So what can we use in addition to NSAIDs besides aspirin? What else can we use? So we can use colchicine. So what is colchicine? This is a drug that inhibits microtubule assembly and inhibits LTB4. So what do we know about LTB4? LTB4 is one of your most potent chemotactants. So it is a chemical that attracts and activates neutrophil recruitment. And we know when we recruit white blood cells, we cause increased inflammation. So by inhibiting microtubule assembly and LTB4 production, we cause decreased macrophage migration and phagocytosis, as well as reduced neutrophil recruitment. So it is used in the treatment of gout and familial Mediterranean fever, but for the boards, you just need to know it's used for gout, and it can be used in the acute phase of gout. Colchicine, however, is not a very safe drug. It does have quite a lot of side effects, and one of those adverse effects which you need to watch out for is diarrhea. According to your pharmacology books, this is the adverse effect that signals toxicity from colchicine. So you do have to be quite careful. It should also not be given in patients with an eGFR of less than 30 because it's renally cleared. And so if somebody does not have an adequate GFR, you would not be able to clear this from your system. Some other quite severe side effects it can cause are bone marrow depression and peripheral neuritis. So we do try to give colchicine for a shortest amount as possible, only during the acute phase of inflammation of gout because of its high-risk side effect profile. Next, we have uricase. So what is uricase? It is a urate oxidase that catalyzes oxidation of uric acid into allantoin, which is a soluble and inactive metabolite. So if we look at the image on the right, if you have purines, which are catabolized into hypoxanthine, xanthine, and eventually uric acid via the function of your xanthine oxidase, instead of this uric acid supersaturating and developing into our joints, if you give your uricase, which are your resburicase and pegloticase, you can convert it to allantoin, which is soluble and inactive. So we only give this in severe refractory gout because it is given as an infusion typically. So you can also get infusion reactions and anaphylaxis in patients who are given this medication. Furthermore, if you give pegloticase, up to 90% of patients will develop antibodies to it, meaning they'll become resistant to it and it will become less effective with chronic use. So next, we have your uricosuric agents, so things that will promote excretion of your uric acid. So kanina, what else was a uricosuric agent? It was high-dose aspirin, diba? Kasi it prevents the reuptake of your aspirin. So what are your uricosuric agents that you need to know? You need to know probenecid and lesinurad. Those are the two drugs you need to remember, probenecid and lesinurad. They will compete with uric acid for reabsorption in the proximal tubules via the URAT1 transporter. So the uric acid, is transported back into circulation. And when you give probenecid and lesinurad, they will compete with this. Okay. So, of course, its use is in gout. It can cause some GI irritation, as with most medications. If you're not sure what side effects it causes, if you can say something like nausea and vomiting or diarrhea, you will very likely be correct. Okay, so what are some things to note about probenecid and lesinurad? They can precipitate acute gout during the early phase of a drug action. And the way to prevent acute gout when giving these uricosuric agents is by co-administering with colchicine or indomethacin. They can also inhibit the secretion of your weak acids. Okay, so why do they inhibit the secretion of your weak acids like your penicillin and your methotrexate? So essentially, you have an organic ion transporter, which is your URAT1. So uric acid is reabsorbed, and they secrete organic anions and monocarboxylates. So by preventing the reabsorption of uric acid, you also prevent the excretion of weak acids. And some drugs are weak acids, like penicillin or methotrexate. Therefore, if you give penicillin with probenecid, for example, you would increase the antimicrobial property of penicillin because it stays in your body longer, so the therapeutic effect is prolonged. At the same time, if you give it with methotrexate, the toxicity of methotrexate increases because it stays in your body longer. Now, because this is a drug that acts on your kidneys, a required minimum of 30 is a GFR that you need to use. Okay. Next, we have your xanthine oxidase inhibitors, which are arguably the most important drugs when we talk about the treatment of gout. So we have two that you need to know. It's your allopurinol and your febuxostat. Remember that xanthine oxidase is an important enzyme in the catabolism of purines, and the eventual product or the end product of this catabolism is your uric acid. So let's look at the pen. Yep. So look here. Via the action of xanthine oxidase, hypoxanthine becomes xanthine, and xanthine then becomes uric acid. So allopurinol and febuxostat have the same mechanism of action, but they have some key differences, which I'll discuss here. So allopurinol is an irreversible inhibitor of xanthine oxidase, whereas febuxostat is reversible, okay? Allopurinol, irreversible. Febuxostat, reversible. Allopurinol is first line for the treatment of chronic gout, whereas febuxostat is only used in patients who have allopurinol intolerance or if they have tried other uric acid lowering agents, but it did not work. So febuxostat is not first line. Another thing to note about azathioprine and febuxostat is that allopurinol, because it is irreversible, is a more potent inhibitor of the metabolism of your mercaptopurine and your azathioprine. So remember, mercaptopurine and azathioprine, as I discussed earlier in your Dmards, they are drugs that are inactivated by xanthine oxidase. So if you stop xanthine oxidase, you stop their inactivation, therefore you increase the risk of their toxicity. Both of these drugs are withheld for 1 to 2 weeks after an acute episode of gouty arthritis because giving febuxostat or allopurinol can trigger another acute attack. So remember, kapag acute attack, we only give your Nsaids and your colchicine. Now, febuxostat is actually more effective than allopurinol, but why is it second line? So a study was conducted on patients who were taking febuxostat, and they found that febuxostat had an increased risk of cardiovascular mortality, especially in patients who had pre-existing atherosclerosis or pre-existing coronary vascular disease. So that is why febuxostat is not a first-line agent and allopurinol is used as first-line, even though febuxostat is technically more effective than allopurinol in lowering your uric acid. Okay, so these are two very important drugs to note in the management of gout. Now let's just answer a few questions about your gout drugs. Which drug increases the renal elimination of uric acid? Febuxostat, allopurinol, probenecid, or colchicine? So remember, it's your probenecid. Febuxostat and allopurinol are your xanthine oxidase inhibitors. Colchicine is a microtubule and LTB4 inhibitor, all of which can be used in gout, but the only one that is uricosuric in this choice is probenecid. Ano yung isa pa? Lesinurad. Probenecid and lesinurad. Which of the following drugs is likely to increase the toxicity of penicillin? So again, this is your probenecid. So remember, probenecid inhibits the reabsorption of uric acid, which is your URAT. But at the same time, it also inhibits the excretion of your weak acids, such as your penicillin. So you'll see here in this figure, Doc, bakit may uric acid din dito? If it's inhibiting also the excretion of uric acid, shouldn't it just balance out with its inhibition of reabsorption? So I understand the concern, but blocking of URAT is the predominant mechanism. So blocking of this is the predominant mechanism for probenecid's uricosuric effect. So this part where it blocks the excretion of weak acids is only a much milder effect compared to its uricosuric properties. Your uncle was started on colchicine by a rheumatologist after a lechon spree triggered his gout. He asks you what side effects he should be most wary of. What should you say? So again, which of these side effects is a trigger to suspect colchicine toxicity? It is your severe diarrhea. So at doses for gout, colchicine frequently causes significant diarrhea, and this can signal colchicine toxicity. Okay, so that's it for your NSAIDs, your DMARDs, your acetaminophen, and your drugs used in the treatment of gout.